Imagine trying to have a bowel movement and nothing happens, no matter how hard you push. Not because you haven't eaten, not because you're dehydrated, but because the stool itself has become physically lodged in place. Most explanations stop at eat more fiber, drink more water, but what's actually happening inside the body is far more specific and far more revealing than that. To understand this properly, it helps to separate two things that get lumped together constantly: ordinary constipation and true fecal impaction. Ordinary constipation means bowel movements are infrequent, stool is harder than usual, and there's some straining involved. It's uncomfortable, but it resolves. Fecal impaction is a different situation entirely. This is when a mass of stool becomes so hard, so dry, and so large that the body physically cannot move it out on its own. It sits in the rectum, the final holding chamber of the digestive tract, acting almost like a plug. The rectum is designed to expand temporarily, store stool for a short period, and then signal the brain that it's time to go. It's not meant to hold on to material for extended periods. When it does, for days or sometimes even longer, the stool inside continues to lose moisture, becoming denser and harder to pass with every hour that goes by. At a certain point, it crosses a threshold. It's no longer a matter of needing a little help. It has become an obstruction. This is the part that a quick appointment often doesn't have time to fully explain. So let's slow down and look at exactly how this buildup happens. Everything starts in the colon. As stool moves through, one of the colon's main jobs is reabsorbing water back into the body. That's completely normal and necessary. The problem arises when stool moves through too slowly. The slower it travels, the more time the colon has to pull water out of it. Stool that might have been soft and easy to pass on day 1 becomes noticeably firmer by day 2, and by day 3 or 4 it can become rock hard. At the same time, something else is happening at the rectal level. Each time stool sits there without being expelled, the rectal walls stretch to accommodate it. Over time, with repeated stretching, the nerve endings responsible for sensing that stool is present and signaling the urge to go can become less responsive. This is sometimes described as the rectum becoming desensitized. The urge to go, which should be a strong and clear signal, becomes weaker and easier to ignore, or in more advanced cases, it may barely register at all. There's also a coordination issue involved. Passing stool isn't just about the urge. It also requires the pelvic floor muscles and the anal sphincters to work together correctly, relaxing at the right moment to let the stool through while the abdominal muscles help push. When someone has been holding stool in for a long period, or straining incorrectly, this coordination can break down. The muscles may tighten instead of relax, working against the process instead of assisting it. So now there are 3 things stacked against the body all at once: a stool mass that's too hard and dry to move easily, a rectum that's less sensitive to the pressure building up inside it, and muscles that may not be coordinating properly to push it out, even if the urge is felt. This combination is exactly why fecal impaction doesn't resolve the way ordinary constipation does. It's not simply a matter of waiting it out or trying a little harder. The physical conditions inside the body have shifted into a different category altogether. And this stretching and change in sensation is exactly where one of the strangest, most misunderstood symptoms comes from. Something that confuses people because it seems to contradict everything they think they know about constipation. Before we get into exactly what that symptom looks like, there's something worth pausing on. Most of the advice people hear for a sluggish, backed-up gut, more fiber, more water, more probiotics, only addresses the surface of the problem, not the actual mechanical reason things get stuck in the first place. There's a completely different angle on this, tied to an unusual underwater ingredient that's been used for thousands of years in places where this exact problem is far less common, and it works through a mechanism almost nobody talks about. If you want to see the full explanation of how it works, point your phone's camera at the QR code on the screen right now, and you'll also find a link pinned in the comments. Now back to that strange symptom. Here's what happens. When a hardened mass sits in the rectum for an extended period, liquid stool from higher up in the colon continues to be produced and continues to move downward, but it can't get past the blockage. Instead, it finds the path of least resistance, which is often around the edges of the hardened mass, leaking out in small amounts. To the person experiencing this, it looks and feels exactly like diarrhea. There's unexpected leakage, sometimes frequent, sometimes messy, and it seems to make no sense alongside days of not being able to go. This is often called overflow diarrhea, and it's one of the most misunderstood symptoms in this entire condition. Someone dealing with it may reasonably assume the problem is loose stool, not blockage, and reach for an anti-diarrheal medication. But that can actually make the underlying impaction worse, because those medications work by slowing down bowel movement even further. The real issue was never too much movement, it was a complete blockage further up, with liquid finding a way around it. This paradox, appearing to have diarrhea while actually being severely constipated, is exactly the kind of detail that a rushed conversation tends to skip over, yet it's one of the clearest signs that something more than ordinary constipation is happening. Beyond this paradox, there's a wider set of warning signs that often get missed simply because they don't sound like classic constipation symptoms. Lower abdominal pain and bloating are extremely common, caused by the buildup of pressure and gas that has nowhere to go. Many people describe a persistent feeling of fullness or pressure in the rectal area, almost like something is there and needs to come out, even after attempting to go. Straining without any real relief is another key sign, along with passing only small, hard, pellet-like pieces of stool instead of a normal, complete movement. Some people also experience nausea and a noticeable drop in appetite, since a backed-up digestive system can affect the desire to eat at all. Lower back pain is sometimes reported as well, caused by the pressure radiating outward from the pelvic region. In some cases, especially when the impaction is significant, there can even be urinary symptoms, difficulty fully emptying the bladder, or a frequent urge to urinate because the swollen rectum is pressing against nearby structures. None of these symptoms on their own necessarily point to fecal impaction, but together, especially alongside several days without a normal bowel movement, they paint a much clearer picture than constipation alone would suggest. Certain groups of people face a significantly higher risk of developing this condition, and recognizing these risk factors matters, especially for caregivers looking after someone who can't easily communicate discomfort. Older adults are among the highest risk group, partly due to decreased mobility, weaker abdominal muscles, and often reduced fluid intake. People who are bedridden or have limited mobility for any reason face a similar risk, since physical movement plays a real role in stimulating bowel activity. Anyone taking opioid pain medications should also be aware, since these medications are well known for slowing down the digestive tract considerably. People living with neurological conditions, including spinal cord injuries, multiple sclerosis, or Parkinson's disease, often experience impaired nerve signaling in the bowel region, which interferes with both the urge to go and the coordination needed to pass stool. Long-term or repeated misuse of stimulant laxatives can also contribute, since the bowel can become less responsive over time when it's regularly forced into action artificially. Chronic dehydration and diets very low in fiber remain two of the simplest, most common contributing factors across every age group. And pregnancy, due to hormonal changes and physical pressure on the digestive tract, adds another layer of risk for many women. What makes fecal impaction more serious than most people initially assume isn't just the discomfort of being unable to go. It's what this buildup can start to affect elsewhere in the body once it's allowed to persist. The rectum doesn't exist in isolation. It sits close to other important structures, including the bladder, and when it becomes overly distended from trapped stool, that swelling can physically press against the bladder itself. This pressure can interfere with normal urination, leading to a sensation of incomplete emptying, increased urgency, or in some cases, difficulty urinating at all. What looks like a bladder problem may actually be the downstream effect of a rectal one. In people with spinal cord injuries, especially those affecting the upper spine, there's a more serious and less commonly discussed complication called autonomic dysreflexia. This is a reaction where a source of irritation below the level of the spinal injury, in this case a rectal impaction, triggers a sudden and dangerous spike in blood pressure. Because the nervous system's usual regulation is disrupted, the body can't properly manage this spike, and it can escalate quickly into a medical emergency involving pounding headaches, flushing, sweating, and a heart rate that swings unpredictably. For someone living with a spinal cord injury, an overlooked case of fecal impaction isn't just uncomfortable, it can become genuinely life-threatening, which is why bowel management is taken so seriously in that population. In older adults, especially those in long-term care settings, fecal impaction can present in a way that has almost nothing to do with the digestive system on the surface. Confusion, agitation, or a sudden change in mental clarity are sometimes the first noticeable signs, and they're frequently mistaken for an infection, a medication side effect, or an unrelated cognitive decline. This happens because the body, dealing with internal pressure, discomfort, and the physiological stress of impaction, can react in ways that affect overall functioning, particularly in someone whose system is already more fragile. It's a reminder that this condition doesn't always announce itself with obvious digestive symptoms, especially in older patients. There's also a physical risk to the tissue itself. When a hard stool mass presses against the rectal walls for an extended period, it can create areas of irritation, ulceration, or even minor tears from the ongoing pressure and friction. In more severe or prolonged cases, this sustained pressure can restrict blood flow to the area, which is a serious complication that requires prompt medical attention. Given everything the body goes through during a prolonged impaction, it's worth being clear about the point where this shifts from something to manage at home into something that requires urgent medical care. Certain signs should never be brushed aside or waited out. Severe or worsening abdominal pain, especially if it's sharp or comes in waves, is one of them. Persistent vomiting, particularly if it's frequent or contains material that looks like stool, is another, since this can indicate the blockage has escalated into a full bowel obstruction. A fever alongside abdominal pain and constipation suggests the body may be responding to an infection or inflammation, not just a simple blockage. Rectal bleeding, especially if it's more than a small amount or appears alongside severe pain, deserves prompt evaluation rather than a wait-and-see approach. A complete inability to pass any stool or even gas for an extended period is a significant red flag, since it suggests the blockage may be total rather than partial. And in elderly individuals, any sudden onset of confusion combined with any of these digestive symptoms should be treated as a reason to seek care quickly, not dismissed as an unrelated issue. None of this is meant to cause alarm over ordinary occasional constipation, which almost everyone experiences at some point and which typically resolves on its own or with simple adjustments. The distinction lies in duration, severity, and the presence of these additional warning signs working together. A single uncomfortable day is very different from several days of straining, leaking, bloating, and pain that continues to build. Recognizing where that line sits is exactly the kind of practical knowledge that tends to get lost in a short, rushed conversation. Yet it's the difference between catching something early and letting it progress into a more serious situation. Understanding why this condition tends to fly under the radar in typical medical conversations helps explain why so much of this information feels new, even though none of it is particularly obscure or experimental. A standard appointment is often short, sometimes just a few minutes, and constipation is an extremely common complaint. Because of that, the default response tends to be general advice. Increase fiber, drink more water, consider a mild laxative. For the vast majority of people with ordinary occasional constipation, that advice is completely appropriate and effective. The issue is that this same general advice gets applied broadly, even to situations that have already progressed into true impaction, where the mechanics of the problem require a different approach entirely. There's also a natural layer of discomfort surrounding this topic. Bowel habits are one of the most private aspects of health, and many people minimize their own symptoms out of embarrassment, describing things as a little constipated, when the reality is several days of complete blockage with overflow leakage. Without a detailed description, it's difficult for a clinician to distinguish between a mild case and one that has moved into more serious territory, especially in a short visit. This isn't a matter of anyone withholding information intentionally. It's more that the system of quick appointments, common assumptions, and patient hesitancy tends to average out toward the simplest explanation, even when the underlying reality is more specific. Once impaction is recognized for what it is, addressing it usually requires more than dietary changes alone, at least in the short term. Softening the existing mass is typically the first priority, which may involve oral or rectal treatments specifically designed to soften hardened stool and stimulate its movement. In some cases, manual removal by a trained professional becomes necessary, particularly when the mass is too large or too hard to pass, even with softening treatments. This might sound intense, but it's a recognized common procedure precisely because home remedies alone cannot resolve a true impaction once it is fully formed. Attempting to manage a significant impaction solely through over-the-counter fiber supplements or increased water intake without addressing the existing blockage directly often leads to continued discomfort without real progress. After the immediate impaction is resolved, attention typically shifts toward preventing it from happening again, since without changes, the same conditions that led to the first episode can easily lead to another. This generally involves a combination of adequate fluid intake, consistent physical activity when possible, a diet that includes enough fiber to keep stool at a manageable consistency, and importantly, responding to the urge to go rather than delaying it repeatedly. That last point matters more than people often realize. Every time the natural urge is ignored, whether due to being busy, uncomfortable surroundings, or simple habit, the rectum stretches slightly to accommodate the extra volume, and over time, repeated stretching is part of what dulls the signal in the first place. In people at higher risk, such as those with limited mobility, neurological conditions, or those on medications known to slow digestion, a proactive bowel management routine is often recommended specifically to prevent buildup before it starts, rather than treating it after it becomes a problem. What all of this adds up to is a clearer, more complete picture than the usual shorthand of just eat more fiber. Fecal impaction is a distinct mechanical event within the body, shaped by water reabsorption, nerve desensitization, muscle coordination, and time. It can produce symptoms that seem contradictory, like diarrhea appearing alongside severe constipation. It can affect people well beyond the digestive system, reaching the bladder, blood pressure regulation, and even mental clarity in more vulnerable individuals. And it carries a set of warning signs distinct enough to separate it from an ordinary rough week of bowel movements. None of this replaces the value of a proper evaluation when something feels off. But understanding the mechanics behind it means recognizing symptoms earlier, taking persistent warning signs seriously, and knowing that a body that feels stuck in this particular way isn't something to just wait out indefinitely. Sometimes the most useful kind of medical knowledge isn't the most dramatic. It's simply the detail that was always relevant, just rarely given the time to be fully explained.